Welcome to Catalyst Medical Review. Today we'll be talking about pharyngitis. Group A streptococcus, also known as Streptococcus pyogenes, is a gram-positive aerobic extracellular organism. They are gram-positive cocci that grow in chains. It can cause both invasive and non-invasive disease and has non-suppurative sequelae. Group A strep exhibits beta hemolysis, which is complete hemolysis when grown on blood agar plates. Here are some diseases that are caused by Group A streptococcus: strep throat, scarlet fever, impetigo, necrotizing fasciitis, cellulitis, rheumatic fever, toxic shock syndrome, and post-streptococcal glomerular nephritis. Group A streptococcal pharyngitis is an infection of the oropharynx. The incubation period of Group A strep pharyngitis is approximately 2 to 5 days. The clinical features: Group A strep pharyngitis is an acute pharyngitis that commonly presents with sudden onset of sore throat, odynophagia, and fever. Other common symptoms that may present include headache, nausea and vomiting, and abdominal pain. There are clinical features that need to be absent in order to validate a bacterial etiology, and these include cough, rhinorrhea, hoarseness, oral ulcers, and conjunctivitis. These symptoms strongly suggest a viral etiology. The clinical examination: patients with Group A strep pharyngitis usually present with pharyngeal and tonsillar erythema, tonsillar hypertrophy with or without exudates, palatal petechiae, anterior cervical lymphadenopathy, and a scarletiniform rash. Here are some special considerations. Respiratory disease caused by Group A strep infection in children younger than 3 years old rarely manifests as acute pharyngitis. These children usually have a mucopurulent rhinitis followed by fever, irritability, and anorexia, and this is normally called streptococcal fever or streptococcosis. In contrast to typical acute Group A strep pharyngitis, this presentation in young children is subacute and high fever is very rare. The transmission: Group A strep pharyngitis is most commonly spread through direct person-to-person transmission. Typically, transmission occurs through saliva or nasal secretion from an infected person. People with Group A strep pharyngitis are more likely to transmit the bacteria to others than asymptomatic pharyngeal carriers. The diagnosis: patients with clear viral symptoms do not need testing for Group A strep. However, clinicians cannot use clinical examination to differentiate viral and Group A strep pharyngitis in the absence of viral symptoms. Clinicians need to use either a rapid antigen detection test, abbreviated RADT, or throat culture to confirm Group A strep pharyngitis. The rapid antigen detection test have high specificity for Group A strep, but varying sensitivities when compared to throat cultures. Throat culture is the gold standard for diagnosing Group A strep. Clinicians can use a positive RADT as a confirmatory test of group A strep pharyngitis in children. However, clinicians should follow up a negative RADT in a child with symptoms of pharyngitis with a throat culture. Clinicians should initiate antibiotics if the callback throat culture is positive. The treatment. Penicillin or amoxicillin is the antibiotic of choice to treat group A strep pharyngitis. There has never been a report of a clinical isolate of group A strep that is resistant to penicillin. However, resistance to azithromycin and clarithromycin is common in some communities. For patients with penicillin allergy, recommended regimens include a narrow-spectrum cephalosporin, such as cephalexin or cefadroxil. Clindamycin and azithromycin and clarithromycin may also be used. Treatment with an appropriate antibiotic for 12 hours or longer generally eliminates a person's ability to transmit group A strep. People with group A strep pharyngitis should stay home until they are afebrile and 12 hours after starting appropriate antibiotic therapy. The complications. Non-suppurative sequelae of group A strep pharyngitis include acute rheumatic fever, post-streptococcal glomerular nephritis, and impetigo. These complications occur after the original infection resolves and involves site distant to the initial group A strep infection site. They are thought to be the result of the immune response and not of direct group A strep infection. This concludes our presentation on group A strep. I do hope it serves the purpose of helping you review for your upcoming exam. Thanks for listening, and I wish you well.